Uh, Good morning, everybody. Dr. Parekh, who is the convener of this small incision cataract surgery course, and she has operated near about 85,000 cataract. The only lady in India or abroad who has done maximum surgery in that SICS also. Parikshit Gokte, who is a scientific committee member and doing SICS and FECO both. Santosh Bhide, who is now the Maharashtra Ophthalmic Association President and doing SICS. Myself is Dr. T.P. Lahane. And I will invite Dr. Ragini Parekh as the Kamaljit Singh is in traffic, so he will be coming. And Ragini is going to speak to you.
Thank you, sir. My teacher and guru, Padma Shri Dr. Lahane, sir. Dr. Parikshit Gokte, who is a member of the scientific committee and who has helped in making this lovely program. Dr. Santosh Bhide, who is the president of the Maharashtra Ophthalmic Society. Dr. Kamaljit Singh, sir, is held in traffic and he will be coming. My senior teachers, colleagues and friends. I really thank the AIOS and the host for this wonderful arrangement and giving me this opportunity. Thank you, sir. So, SICS still remains one of the most important surgeries in India today. We do phacoemulsification, but 80% of the surgeries in India are by phacoemulsification. What is important is that you have to optimize. Our goal is to do phaco surgery to give the patient 6/6 vision, and it is a cataract refractive surgery. So how do we optimize SICS so that the patient gets the best results? There are various steps in SICS surgery, which is anesthesia, the post-operative course, astigmatism, and the lens that we are going to use. So these are the various factors which will determine our optimization. Now, in phacoemulsification, we always do topical anesthesia. And that is one of the points that is discussed, that in phaco, topical is possible, and in SICS, you have to do only peribulbar. But with patients coming with a lot of systemic diseases who are fit only for topical anesthesia, what can be done in SICS? So, there are various references and articles by people which say that it can be done with topical anesthesia, with intracameral lidocaine, or a subconjunctival anesthetic agent. And what are the results? So many people are using jellies, and in a large volume surgery, Lahane sir also does it under subconjunctival injection. So, this is how a patient will look. So the causes of pain in surgery are stretching the zonules, inflation of the anterior chamber when you are putting viscoelastic, the nucleus delivery, and the main is iris touch. It is the iris which is very delicate, and the minute you handle the iris, the patient gets pain. So all the steps in phaco, topical, can be done in SICS if you are very careful and you are planning it well. So this is the step one, this is a video. This is on one side you have the corneal tunnel, and as we know it can be done under topical. Now when you are doing this step and you are making the tunnel, if you are giving a subconjunctival injection there, then there will be no pain, and we have done it. You have to be careful when you hold the eyeball so that there is no stretching. So making the tunnel is the important part where the patient can pain, because you are cutting the sclera. So as you can see, this is the entry. This is the entry in the phaco surgery and in the tunnel. Once the tunnel has been made, if the pupil is dilated and you are not touching the iris, the patient will not get any pain. The side ports are not a problem, and then the capsulorhexis. So these are the side-by-side videos where you are seeing the comparison. Hydrodissection, very little amount of fluid should be used so that there is no filling of the anterior chamber and the patient does not get pain. If you are not touching the eyeball or if you are not pulling it too much, then the pain will not be there. So as you can see, this is hydro and pre-delivery steps. This is another case where you are seeing a Blumenthal surgery, the phacoemulsification, rhexis and the hydro procedure in this space. This patient where it can be still done under topical. And rotation of the nucleus. Nucleus delivery should not be causing a problem. Now when we have the intraocular lens, you are putting in a foldable lens and you are holding on the AC maintainer, so you don't have to touch the eyeball. And here also you are putting in an intraocular lens under the AC maintainer and dialing it. So in short, topical anesthesia is possible even in SICS surgery. The post-operative course of the patient, let us see this. Now what are the problems? You will always notice that the patients of phaco have a very, very quiet eye. How can this be achieved in SICS? So I used to always find a difference in my patients and Dr. Lahane sir's patients. And when we take the first step of conjunctival hood or the flap very lightly, then that can happen, it can retract. But making the conjunctival flap in such a way that it covers the incision very well, there are two advantages to this. That one, the patient's wound is not seen, it is covered very well, and there is no pain. So many a times our second day post-op patients, unless you lift the upper lid, you do not find any difference in phacoemulsification and in SICS. There is no lid edema, there is no pain, and there is no watering. Now, the patient will again say that, in topical, my eye was not patched by the other doctor in phacoemulsification. So in phacoemulsification, in topical, you do not patch. But if the wound is sealed properly and it is covered by the conjunctiva, then you need not patch if the patient has undergone topical anesthesia. Refraction in SICS, that is an inherent one diopter cylinder, which can maybe avoided or not avoided in phacoemulsification, but nowadays with proper incisions and good techniques, refraction can be given as early as 4 weeks. So astigmatism, like I said, is always an inherent part of the sclerocorneal incision. So your incision, if it is 4 millimeters, there will be 1 diameter, and as the incision increases. So in soft cataracts, you can get away with smaller incisions and making the tunnel as a funnel so that you increase the length without increasing the length which is causing astigmatism. Proper construction of the tunnel will help control the astigmatism. So modification of the incision and the tunnel. So depending on where the astigmatism is, if you study the patient, you can modify or reduce or control the astigmatism. So as you can see, this is a superior incision which will induce against the rule astigmatism. There will be lid pressure effects. It will be near the visual axis. And if you have a superotemporal or temporal incision, it will induce with the rule astigmatism. There are no pressure effects. It is away from the visual axis. It induces less astigmatism. But one has to be very careful because they are not protected. Temporal incisions are open because they are in the palpebral fissure and they are more likely to be harmful to the patient. So you have to decide whether you like astigmatism or the patient is non-compliant. So everything has to be decided with the safety of the patient. It is very, very important not only for SICS but for every cataract patient that your keratometry, biometry and topography today is very, very important. Many a times you see results of the patients are not expected as expected, and nowadays with the topography you see so many patients who appear to be normal or with minor cylinders have keratoconus. So topography is the advanced tool. Even if it is not available, one has to be careful, but we sometimes depend on residents or optometrists for optical biometry and keratometry, but one has to be very, very careful. So it provides a steep and a flat axis, as you can see. And you have to ask the patient for history of glasses, what is the current refraction, what is the aberrometry whenever it is available. If it is not available, one must not feel that we do not have instruments worth crores of rupees, but even with the basic sciences you can do good for the patient. So as you can see over here with your A scan reading, you can determine the astigmatism and your incision. So as you can see, This is the 90 degrees and the 180 degrees and 114 degrees at astigmatism, and you can plan your tunnel which is superior-temporal. So one has to take a little more time, learn a lot of physics and plan surgery well and customize the surgery to give good results. As you can see over here, I'm a left-handed surgeon. You saw some videos of right-handed surgery which are Dr. Lahane sir's with the Blumenthal technique. As you can see over here, you are making the conjunctival flap not at 12 o'clock so that it will cover like a hood. Very nicely preparing this and making the tunnel, doing proper cautery, not excessive. This is the corneal tunnel, which is a frown incision, a modified frown and not a smile. As you can see, this is the funnel, or you can see the scleral pockets which are dissected very well. Half thickness of the sclera entering into the cornea and making a perfect tunnel. Learning it, which is so easy. So many a times we see tunnels which are straight. This dimpling and anterior chamber entry and entering, like you see, you cut when you go in, and this scleral pocket gives you a large space to deliver the nucleus without increasing the incision. As you can see, this incision on the measurement is only 5 millimeters. So many normal looking cataracts can be removed, and in case you cannot, so extension of the tunnel. So whenever you extend, you have to extend internally to reduce. As you can see, this is a brown cataract. A very hard cataract. The glide is already in place, but it is not going to come out. Yes, I'll finish. So extending the tunnel will help you to remove the nucleus. As you can see, the pockets are being extended and not the horizontal cut. This will help to deliver the nucleus. So as you can see, this nucleus is delivered. And you can see how brown and hard it is. But without damaging the iris, without the iris coming out, and doing a very good surgery without damaging the... So what about the intraocular lenses? Many people and many patients want premium lenses. So yes, if the incision is small, if it is a small cataract, then you can do premium lenses and it can be astigmatically neutral. So you can make it a perfect surgery. Pre-operative parameters are important. Surgical astigmatism is important. A bad endothelial count, hard cataracts, you get better results with SICS. We must not think that we are inferior. It is a premium surgery. We do thousands and thousands of SICS surgeries. Though if I was operating in JJ day before yesterday, I've done 50 phacoemulsifications and sir has done maybe 60 or 70. But you should always have SICS in your armamentarium to give good results to the patients. I thank you all for a patient listening. Thank you so much. The next talk, sir?
Yeah. The next talk is by Professor Lahane sir, and he's going to talk on difficult cases, the simple way out. And there is a saying that when things go tough gets going. So whenever the cataract is hard, let's listen to Dr. Lahane sir, how he manages it. And excellent talk by Professor Ragini ma'am.
Yeah. Thank you very much. Now, basically, there is no any difficult cases in SICS. The difficult cases are there in phaco, which are helped by the SICS surgeon while doing phaco or before doing phaco. That depends on the surgeon. If surgeon wants to do phaco and then terminate in between, or want that he should operate with the SICS, that depends on his thinking. Now see the so many cases. You can see the cornea here, and in that phaco it will be very difficult. Subluxated lens, posterior polar cataract, white mature cataract, corneal dystrophies, PXS. So in that always nucleus goes behind, uveitis, black cataract. So these are the cases where you must think you should go with the SICS or you should go with the phaco. If you go with the SICS, your life is increased. If you go with the phaco, every case reduces your minimum 5 days, 10 days, 7 days life, because there it is very difficult to operate. Now see, when there is a small incision, in the small incision, it may be, you can say, functional, fixed, pseudo-explanation or difficult rhexis. There may be a PC tear, oil implantation will be a problem, or there may be a zonular weakness may be there. So when you go to the management strategies, so strong mediatics, yes, you are using strong mediatics, then the viscomydriasis, or you can use the iris hooks, or you can use the pupil expanders. Previously we were doing sphincterotomy, but nowadays we are not doing, but yes, you can do small sphincterotomies and CTR in cases of the zonular weakness, or you can say there is a PXS CTR before removal of the lens. Now another managing strategy is all parameters should be less than normal, and the use of visco. In between you should use the visco so that second day cornea will be good. So this is the SICS in the small pupil. See here, what I am doing is the small pupil here, and this is just doing the, see here, whenever you are doing the incision, so incision should be 5 or you can say 5.5, but sometimes what happens, I have seen so many cases, there is a very wrong horizontal incision, and that gives a very big astigmatism, and patient is never happy. So we must plan our incision, and this incision where we can make the pockets, and these pockets will not take part in the astigmatism. And so see here, so I am spending my time to the making the pockets, and then I am doing the rhexis. Now this rhexis I am doing under the AC maintainer. I never use any visco in my SICS surgery, and here you can see I am using the iris. See here, it is going beyond the iris, and support of the iris I am using for the large rhexis. So it means you can do the rhexis, large rhexis in the small pupil, and then I am extending it. Now once I have extended, see here on both sides, and then the hydrodissection. So here you will have to remove the nucleus from two places. One is from the small pupil. See here, I deliver it from the small pupil by the rotation. You just rotate gradually, if not by the, you can say this, and then I use the just a polypropylene glide. So by this glide, and whenever you are putting the glide, this glide should not go beyond the iris. If it goes beyond the iris, then there may be a PCTR. So like this, I can do the in the basic is you must repose the conjunctiva. The hard cataract, it is always a large nucleus. Then here the molding. You see in the cortical cataract molding is there. Here it is no molding, and so endothelial damage is possible in the nuclear cataract. So management strategies, the adequate scleral pockets. I am not saying that wound should be larger, but pocket should be this, and the tunnel instead of 5.5, you go for the 6 millimeter tunnel, and you must go for the large rhexis. In large rhexis, nucleus will come out. Otherwise, it can take the you can say the capsule as a whole. So you can see this is the nucleus where I am doing the. You can see this. My tunnel here is larger than what you have seen in the small pupil. See here, it is near about 6 millimeter. And extension. See, it should not be only horizontal tunnel. You must extend it behind, because nucleus is also thick nucleus. It is not on some paper-like thing we are bringing out. So you will have to open the wound, and for the opening of the wound, you require back cuts or extension. Now see here, again I am doing the rhexis, and this is the rhexis where this is my old video. Now I am using the Blu-rex. That time I was not using the Blu-rex, and I am doing the rhexis. Now once it is completed, you will see whenever I am going in, cutting. So whenever you are going in, you cut. Whenever you are coming out, don't cut. Otherwise you will see the V-shaped racks to the cornea, and then it is very difficult. Now see here, my glide has gone in up to the iris, and the nucleus, which is a hard nucleus, I am not bringing as a whole nucleus out. Partial nucleus is brought out and then that can be rolled out, and you can see then this is an aspiration cannula that we have made. So here it goes from 1.1 incision and then I can dial the lens in the, you can see in the back. So this is the hard cataract, we can go ahead. The another, you can just see the another black cataract which is there. Now this is in Maharashtra there is a region called Marathwada. There is no water there, and because of this I am from that Marathwada. The patient comes to me, and these patients are always sent to me because this is very hard cataract. Sometimes these patients may ask me phaco. I always say I can't do phaco, I will do SICS, and that helps me for all things. It means I can sleep in the night. See, if you do the phaco in this case, yes, you can do phaco. But whenever you are doing phaco, you can throw the lens, as the name of the phaco is there, in the vitreous. Maximum thing you can do in such nucleus is by any means, because posterior fibers which are there in this nucleus is very difficult to break those fibers by phacoemulsification. So in such situation, when there is a black cataract, you can see this is a very, very black cataract, and not only the black, you can see the thickness of the cataract also. And when this is so much thick cataract, so you see here, so always better to operate by SICS, and once you operate by SICS, second day, it is not required to tell the patient that there is air inside, because the cornea is opaque, patient is unable to see, and 8 days your SK will be there. So you can escape from the SK by doing SICS. Now white cataract, here it is a difficult rhexis, poor visibility, you can use the dense nucleus and no glue. Sometimes what happens, you get the tear in the capsule, and there then you can't do the phacoemulsification. So one is the dye assisted rhexis, and you can go for the large rhexis for the nucleus prolapse, and you can do it. And another is a proper internal tunnel dissection. That is what required in the hypermature cataract. I am doing the Blumenthal technique here, and you can see this is the cautery what I am doing. And once I have done the cautery, then I will go and see here the tunnel is done. You can see the tunnel here, it is not required like the nuclear cataract. It is a molding cataract, though it is a hypermature and small one. And first see here the tunnel in the same plane. It should not be different planes. So while you are going inside, that it should be a same plane, and the same plane goes on the both pockets. And once you have made the pockets, inside opening is 7 millimeter, outside is 5.5 millimeter. Because of that you get the engagement of the nucleus. Unless and until nucleus is engaged, don't try to remove it. Otherwise that can cause the problems. So this dimple, whenever you are going in, you must see the dimple. See here, the dimple in the cornea, and you must go 1 millimeter in the cornea. Without that the tunnel is not perfect, and whenever you are removing the nucleus, that time iris will come out. If iris is coming out, means your internal incision is not in the cornea. So that should be in the cornea. See here, the rhexis, I have not done the rhexis. Now here you can see I have just, can see this is a flap technique that I am doing. Envelope it is called as, and here I am removing the nucleus, and once I remove the nucleus, then I will do the rhexis like envelope technique. So it is not required that rhexis is only required. In such cases, it is very difficult to do the phacoemulsification, because you see the capsule. It is an hypermature cataract and capsule is very thin, so the zonules are very weak. So whenever you will do here, the nucleus will go behind. Now you can see the lens is implanted, then I have cut the capsule, and this capsule then I will hold it, and you can do the rhexis, lens is inside, patient is happy. This is very important. Whenever you are doing such thing, patient should be happy. SICS is easy to learn and skill procedure to the master it. Now first surgery to 1 lakh surgery technique remains same. It never changes in SICS. As such, there is no any difficult situation, I have told you, and it is a wonderful weapon. So though you are a phacosurgeon, after that also you please learn SICS, so that whenever there is a difficulty in between, you want to remove the nucleus, you have made a piece and you want to remove the nucleus, better you must know the SICS. Thank you very much.
Thank you, sir. Sir, you with Dr. Kamaljeet Singh, sir, and all have been promoters of SICS, and you talked practically and showed very, very hard cataracts where it would be very difficult to do phacoemulsification. Sir, introduce Kamaljeet Singh, sir.
Kamaljeet Singh, sir, he is our mentor, our guide, our inspiration. And we all are advertising today also SICS, and in that Kamaljeet Singh is also forerunner. Today I will tell you, we do 70 lakhs patient in India every year. Out of that 70 lakh, we are doing 28 lakhs patient with the phacoemulsification. And 42 lakhs patients are today also operated by SICS. So whatever we are thinking, the SICS is inferior, but SICS is only giving the vision to maximum number of the patient. Near about 60% patients are treated with SICS. And Kamaljeet Singh, sir, go ahead.
Thank you, sir. It's a great pleasure speaking with Dr. Lahane, Dr. Agni, Dr. Gokte, and others. And at the outset, I would like to thank Dr. OPS Maurya, who is sitting there, who initiated me to SICS about 25 years back. I am so happy and I am so proud he is sitting here. Thank you, sir. So today I'll be discussing what little bit of changes we have done in SICS. We have been doing SICS starting from 6 millimeters to 7 millimeters or even longer incision. Today I'll be discussing a little bit about making a smaller incision and giving good results with the manual SICS, or you can call it manual phaco today. So I'll be just showing you a few videos, and as you can see here, this is a phacomorphic cataract, and I am doing it through 4 millimeter incision. And you make a tunnel as usual, it's just a straight incision, and then you go and do capsulorhexis. It's slightly difficult to do capsulorhexis in a case where you have a hypermature swollen lens, and you have to be extra careful, and you have to keep on injecting viscoelastic material. You can use costly ones also, or you can do it under AC maintainer, as Dr. Ragni and Dr. Lahane do. So I use forceps to do this capsulorhexis, and here the aim is, because the lens is swollen and large, the aim here is to make a larger capsulorhexis, which should be around 5 to 6 millimeters, so that you can prolapse the nucleus out of the bag, and then you can do a phacosection in these cases and can deliver the nucleus out through a smaller incision. So this is what we do. We do with capsulorhexis, and initially you make a smaller axis, you try to make it, but in a hypermature cataract you will find that it keeps on extending, and after extension you have to be slightly careful and keep pulling it towards center so that your axis remains larger and does not go outside. So it's you make 2 side ports, and then what you do is that you can take a Simcoe cannula to simply clean as you used to do in the past with the mini nuke technique. So here what we do is that we take out the cortical matter and a little bit of epinucleus that is soft before delivering the nucleus out, so that your nucleus becomes smaller and it's easy to deliver it out. So with the Simcoe cannula from the side port I am doing it, because the AC was shallow, so the AC is well maintained, and you can go through the main, and you can see so much of large cortical matter comes out through the side port and main port, and then you slightly increase the incision, and it's done by going downwards, and then you rotate the nucleus out of the bag. It's very easy to rotate it, and hydrodissection should be good so that you can rotate it properly, and then use a Vectis and a Sinskey dialer. No automated equipments are required here to break the nucleus into two pieces. What you do is that you take the irrigating vectors below the nucleus, and on top of this you can use even a needle can be used, but I have used here a dialer, and hold the vectors tightly at one point, and from the top you simply press it, it will break it into two pieces. And then you can deliver the one piece through the vectors and the other piece by simply visco expressing it. You don't need to go again into the anterior chamber to remove the nucleus piece. So this is how we do it. You break it into two, and you can see the remaining nucleus. You are further dividing it and making it vertically long, and then using viscoelastic material you can use it, or you can simply with the irrigating vectors you can take it out if you are finding it that there is a little bit of hypotony. And then you clean the cortical matter from the main port and the side port, and then you can inject a foldable IOL in this case. So it's a phacomorphic cataract, a large nucleus, and you can easily deliver it through 4 to 4.5 millimeter incision. And then after implanting the lens, you can wash the cortical matter and also the visco. This is a softer cataract which has been done through the same incision. The incision is close to the limbus as you do in the phacomulsification, and you make a good wound with the help of a crescent knife, and on the sides also. After doing this, you puncture the anterior chamber again in the same process that you usually do with normal SICS, but the incision here is slightly smaller. Stain the capsule, although it was not needed in this case, but it gives you, if you have not got a very good microscope, then it gives you a good contrast, and you can easily do a capsular access. So a large capsular access is required here. It's not, it's almost of the size of 5.5 to 5 millimeter, and you make two side ports to do a bimanual irrigation aspiration. And you can see I am trying to rotate it after doing hydrodissection, and good amount of hydrodissection should be done, and you should see that your cortical matter is free from the capsular bag, otherwise many a times you will have a zonular dialysis while rotating it. So here what I am trying to show you is that you can, with the help of a Simcoe cannula, you can simply use it as a phaco tip, and can gradually keep on doing it like this, like you do make a trench with the phacomulsification machine, and after making a good deep trench, you further go ahead and make it quite deep so that you can break it into two pieces. And this method I have used in phacomulsification also. You can simply chop it into two pieces with a Sinskey and a dialer and a chopper, and then you can take it with the phacomulsification machine also. You can see this is the simple technique which has been described by Dr. K.K. Mehta. He says that the lens salutes, and if you have made a good trench, then you can break it into two pieces without any problem by using lots of viscoelastic, and then you can make it into smaller pieces again with the two instruments which are manual, and viscoelastic is there. Then you can simply visco express the nuclear material without, and then you can use a bimanual irrigation aspiration to clear the cortical matter, and you will find that it can be easily done even in a larger incision of 4 millimeter through bimanual irrigation aspiration can be done. Even if you don't have a very good phacomulsification machine, you don't need to buy a 70 lakh phaco machine just to say that there is no surge in those machine and there is a sensor. So your sensor is AC maintainer, and you can see I am putting fluid from the other side, and under the fluid I am implanting the lens into the bag. So these techniques can be used for making the incision smaller and implanting a foldable lens. Thank you so much.
Thank you, Professor Kamaljit Singh sir, for those very practical tips, because they are the ones that help. People who are standing at the back, we have chairs over here, about 10-15 vacant chairs. You can come in the front. Now I would request Professor Ragini Parikh to give her next talk. Professor Lahane and Professor Ragini are famous not just for doing very high volume cataract surgeries, small incision and phaco, but also for doing a lot of training that happens in the meetings, whether it is BOA, whether it is AIOS. And in fact, this instruction course has been going on continuously for the last 14 years. And thanks to all the delegates, we've always had it in full halls. SICS, we all know, is a wonderful surgery, and as Sir was saying, it still accounts for the majority of the cataract surgery that is done in this country. And it's not just a fallback surgery or a surgery for the poor, it's a surgery of choice for so many things. So here now ma'am will be speaking on SICS and surface disease, how to tackle it.
Thank you, Dr. Parikshit Bhai, for the lovely words. And when you were not there, I was just telling everyone about the lovely scientific program that you have made great efforts to make, and you being a part of the scientific committee of the AIOS. Thank you for your kind words. So this is another topic that we don't take very seriously. That is SICS and surface disease. So we will be I work at Grant Government Medical College, and the financial disclosure that I have is that Sir always asks the trade for drops for the patients or money for the conferences. Now if you see a patient over here, what happens if you see the lids, carefully observe the lids, and what will happen if we operate this patient. This is the magnified image. As you can see, the meibomian gland and the secretion. So what happens if we operate the patient? You can see the waxy congealed meibum, and you miss this. Okay? So what happens is that what will be the sequelae of this? The patient will complain of foreign body sensation, pain, watering, and the thing is that the patient will be 6/6 but not 6/6. So that is the worst part of it. That you keep on thinking, arey, this patient is 6/6, and he keeps cribbing, and you will be really upset with the patient because the patient definitely is unhappy, but you will be very stressed out and frustrated because the patient can read 6/6. Now what is the definition? In 1995, the definition and classification of dry eyes was that it is a disorder of the tear film due to tear deficiency or extensive tear evaporation which causes damage to the interperipheral ocular surface. And it is associated with ocular discomfort. Then it again changed that it is a multifactorial disease of the tears and ocular surface which results in discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. And it is accompanied by the changes in osmolality. It further changed that it is a multifactorial disease with a lot of loss of homeostasis of the tear film, ocular symptoms which is accompanying them, instability of the tear film, hyperosmolarity, ocular surface inflammation. So as you can see, the definition keeps changing. And when the definition keeps changing, it means that we do not know the disease completely. I just came across a book which is so thick only about the tear film. So we don't take it seriously, or we concentrate only on cataracts. And something that we don't understand completely can cause a lot of trouble to us. So if you miss the diagnosis of dry eye preoperatively, as you can see over here, what happens to the effect of dry eye? Intraoperative, so dry eyes, there may be a misdiagnosis. There may be an intraoperative increased surgical time, incision size, lens hardness. This also affects. There will be inflammation because of the intraoperative problems, and there will be a reduction in the goblet cells. Post-operatively, we give a lot of eye drops, and there are preservatives in the eye drops. And some patients are very happy when you tell them to put drops. They think that by putting more drops it will help, and they keep on putting lots of drops in the eye. So all this can aggravate the dry eyes or cause dry eyes. As you can see, when you stain the tear film, this is how it looks. The patient has a red eye. And what would you like to do? Pre-operatively, you do a Sherman's test, you do the fluorescence staining, you do a T-butt, and you do a meibography. Now normally we don't do all these in our cataract patients. We have a standard format for workup and we work up the patients. And it is not necessary that you do it in all the patients. But in a patient whom you are seeing on slit lamp and you suspect having a disease, then there is no harm, or actually all these should be done. If you see this case, there is a patient who has a 45-year-old male who has a corneal opacity with a PHC cataract. Now there is a parapupillary corneal opacity and a cataract. It is disabling to the patient. You go ahead and do the cataract surgery. We do this so often and it is done every day. Now this is what happened to the patient 7 days after cataract surgery. As you can see, this patient came with a large epithelial defect with infiltrate. The cataract surgery has gone very well and the patient is happy. You have given reasonable results. And why this occurred? So, and this is so disturbing to the surgeon and the patient. So, as you can see over here, what went wrong? So, this healed, but it healed with a larger opacity. The patient was not satisfied. It has now covered the pupillary area. The patient is upset, and you know what happens when the patient becomes upset. Now, what went wrong was that this patient actually must have had old herpes keratitis. Now, sometimes the patient does not give a proper history, or we may have not asked a proper history, and because of the post-operative steroids, the herpetic condition got aggravated, reactivated, and the patient had an epithelial defect. So to correctly get a history, to check the corneal sensations, to find out what happened when the patient had a corneal opacity, and you have to be very, very careful before doing any surgery. The eye has to be quiet, and you have to examine the patient very well on slit lamp with a magnified view, looking for superficial or ghost vessels, and reactivation of the keratitis in case of fever or stress that would have given an indication. Even then, this could have been missed. And so one has to be very careful, and the case is just to say that the ocular surface, which is a very neglected part, needs to be given a proper attention. As you can see over here, this is a mimosa plant which is very, very delicate. So systemic diseases which affect the ocular surface, which like rheumatoid arthritis, the pre-operative factors, the post-operative factors, and the surgical factors all will influence. Systemic diseases like autoimmune disease, rheumatoid arthritis, Sjogren's syndrome. Surgical factors like the incision, additional incisions and the time taken for surgery. Irrigation of the ocular surface. So many a times, like we are in a medical college, the patient is going to be operated under topical anesthesia. You are taping the eye, the patient is sitting outside, and when the patient comes in, the corneal surface is dry. So irrigating the corneal surface, putting viscoelastic on the corneal surface when you are operating, how much concentration of betadine you are using to give the betadine wash. These factors are very, very important, because if the patient has a corneal epithelial defect the next day, you have to put steroids. And if you don't put steroids, the cataract surgery post-op will be affected. If you put steroids, the defect will be a problem. So ocular surface has to be really, really taken into mind. Preoperative factors means examination of the tear film. We may not be specialists in that, but we can find out that what is the change in corneal sensitivity and the ocular surface anatomy. So all these factors are very, very important. We give an array of drops. We give lots of drops. I know a patient with rheumatoid arthritis who was given topical NSAIDs many years back and came to us with corneal melting. From that day, even for retinal problems, I'm so scared to give NSAIDs, and we never give it unless without the cover of artificial tears. And we have seen corneal melting. Self-medication, as we all know, it is the biggest headache in our lives. And aggravation of the previous dry eyes is very, very important. So, refractive surgery, contact lens wear, topical anesthesia, low lacrimal flow, tear hyperosmolality. These are all factors that we have not paid attention to. And after that is that what will we use? These are different types of artificial tears available, and you have to choose each one depending on what type of tear deficiency the patient has. This is not very difficult or complicated, but once you start paying attention to it, it will be helpful. Now you see so many children and young adults who've had vernal keratoconjunctivitis. You start steroid drops for a short period and pulse dose, but the patient is so happy with steroids that without visiting the doctors, we've had patient coming back after 2 years with cataract and glaucoma because they were so happy with the condition that remains stable because of steroids. And this you see very, very common, limbitis, papillae, inflammation. So in these cases, it should be performed only in a quiet eye. You should be aware of topical and systemic immunomodulators, and it's not necessary that you should be the master of all diseases. We have friends who are specialists whose help can be taken. For example, Dr. Sumit Lane is our cornea specialist. My father has Sjogren syndrome and I was treating him, but his eye became more and more red. I thought that he had discharge. I started moxifloxacin. It became worse. He had scleral thinning. And one day Sumit stopped everything, started gentle gel, and my father's problems were solved. So it's important to take the help of a person who is really specialized in the cornea care. And there's no harm because if you are a cataract surgeon, you are not going to see lots of cases of cornea. And you have to decide what is the duration of all these drugs that you're giving. Secondary glaucoma because of the vernal keratoconjunctivitis induced steroid glaucoma should also be addressed. Stevens-Johnson syndrome, ocular cicatricial pemphigoid are all seen and they destroy mucin, aqueous layers, meibomian glands. These are really complicated patients which need a lot of care because of all these problems of keratinization, punctal scarring, symblepharon that the patient has. Trichiasis. And I have seen in North India when I was operating in Allahabad, you see a lot of patients with sequelae of trachoma even today. So you have to be very, very careful. So recommendations are that you have to manage the dry eye, you have to reconstruct the ocular surface, you have to replace the limbal stem cells, dry eye therapy and conjunctival treatment. So it is better to avoid SICS in difficult and complicated cases with xerosis. The conclusion is that you have to be very, very careful. You have to keep dry eyes in mind, not to have post-operative problems. Ocular surface disorder needs a holistic approach. Cataract surgery should be customized for every patient. Pre-operative counseling of the patient will prevent a lot of post-operative headache, and follow-up and use of modulation is important. Thank you so much. I just wanted to highlight that there may be other factors in cataract surgery and ocular surface or dry eyes that need to be addressed during the cataract surgery. Thank you so much, friends.
Thank you, Ragini. Thank you very much. It was an excellent eye-opener. So whenever you are doing the cataract surgery, so you should not just make an hurry, but you must examine patient thoroughly so that post-operatively patient will not eat your head. So now I will invite Dr. Parikshit Gokte, who is a scientific committee member, and he is going to speak to us on the various techniques of the small incision cataract surgery. Though we do few types, but Parikshit, he is a scientist. I always say that he is a scientist. He was selected for IPS, but he has not joined, and he is doing ophthalmology. Parikshit, go ahead.
Thank you, sir. Respected dignitaries on the dais and distinguished audience, I'm speaking on the various techniques of cataract, SICS surgery. Well, nowadays we have a choice between SICS and phaco. And if there is one thing which is different or difficult in SICS, it is first prolapsing the nucleus into the anterior chamber, because sometimes the pupil is not dilated, as Professor Lahane showed. So pupillary dilatation during surgery is a key factor. So we have to have properly dilated pupils. We can do that by using, of course, good mydriatrics, by using NSAIDs, and nowadays we have a lot of pupil expanders and intracameral drugs which can be used. Small pupils make nucleus delivery difficult, and they increase the chance of manipulation of the iris with resultant iritis. This holds true for all the techniques of SICS. If we look at the various techniques of nucleus delivery out of the eye, there is a list of 9 techniques so far. I'll be describing each one of them in a small this, and there are many newer ones that have come, so I will just run you through it. The irrigating vectis, the one that's most popularly used, what we learned in the Arvind Eye Hospital in 1998-99. There is blue menthol, which is followed by Professor Lahane and Professor Ragini. There's the phaco fracture, the phaco sandwich, the phaco trisection, the fish hook technique that is very popular from Lahan, Nepal, which also does literally hundreds of thousands of SICS surgery. There is a snare technique by Dr. Anil Shah of Nandurbar. There is an intra-tunnel fracture from Mount Abu, and there is smart SICS from Pune by Dr. Raut. So the irrigating vectis technique is the one that we all do. I'll be showing you videos of this. It's a very fast procedure. The AC has to be well formed throughout the procedure. And here the brunt of the nucleus, as you can see, is borne by the walls of the tunnel. And if we use a lot of visco from the side port, it is very safe for the endothelium. And we don't need anything extra. So those of us who shifted from ECC to SICS, this was perhaps the easiest technique. So here, as you see, in many ways, getting this nucleus out is like getting the toothpaste out of the toothpaste tube. We open the nozzle and we gently keep on pressing it, and so the toothpaste comes out. So here, as you can see, because more visco is put in, there is good increased hydrostatic pressure. There is a scleral stretching by the nucleus, and because the vectis is just pressing on the lip, the posterior lip, it is opening the mouth and the nucleus is gliding out. This gliding is very, very important. The phaco sandwich technique was first done in 1980s by Dr. Luther Fry, and here the nucleus was squeezed between 2 instruments. Now the problem with the phaco sandwiches in Indian setting, especially in the rural setting or in medical colleges, we get people with very hard cataracts, with very black nuclei. So putting in 1 instrument is a challenge. Putting in 2 instruments is an even bigger challenge. That is why this technique didn't become very popular. Even in the phaco fracture technique by Dr. Peter Kansas, again from the US, popularized in the 1980s. Mind you, this is before phaco became popular in the US in 1990s. We have a bisector or a trisector that divides the nucleus into 3 small pieces. But the same problem which was there with the phaco sandwich is with phaco fracture. Now, one of my colleagues, Sanjay Rasar, had a dissertation for doing this in 1996. The problem used to be that because the nucleus used to be so big, and in those days viscoelastics were not easily available, when we put in 2 instruments, one below and one above, lot of the corneal endothelium would get damaged and patients would not be happy. So this is when the Blumenthal technique came in, and we all know Professor Blumenthal from Israel, who used a sheets glide and an AC maintainer. So all the videos that we saw, most of them of Professor Agini, they are all Blumenthal videos. This kept the anterior chamber formed at all the time. No viscoelastic was needed. In fact, in those days, there was hardly any viscoelastic, and the nucleus just glided outside. So this is a small video. Now this is a black cataract that you see. Now doing a cataract like this by phacoemulsification is going to need a very, very high viscoelastic, a very expensive Elon. You will need to have a very good phaco machine, being very good at doing it, and then perhaps putting in a lens. But what would take anywhere between 10 minutes to 30 minutes, this can be done with SICS in, well, a few minutes without any problem. As Professor Lahane said, there is making a tunnel. We have to be sure that the tunnel is only in one plane, so you just use your hand only in one way. Spend time in making the tunnel. It's very, very important, because if we make the tunnel properly, if we make the side ports properly, then the astigmatism will be less. The tunnel integrity will be good. Here now we are using AC maintainer that is being put in. And once this AC maintainer is put and a tunnel is made, we'll do a CCC. Doing a CCC greatly improves the safety of the procedure. Phacoemulsification was there since 1967, but phaco became popular only after 1993 or 94, when CCC was invented by Dr. Neuhorn, Dr. Gimbel, and the doctor from Japan. So if we do the same for SICS also, then it makes the bag much more stable. It's easier to get the nucleus up. Only the CCC for SICS has to be bigger than the CCC for phaco, because in phaco everything has to be done inside the bag. In SICS, perforce, we have to get the nucleus outside the bag. And for doing that, we need to have a larger CCC. So especially surgeons who do sometimes SICS, sometimes phaco, or one after the other, they sometimes forget, because while doing phaco, especially for premium lenses, toric lenses, we make a smaller CCC so as to have a better centration. For SICS, that is not the case. Once a CCC is made, this nucleus is just prolapsed into the anterior chamber by doing rotation. And as we can see, a sheath's glide is being put in. And once the sheath's glide is being put, if we just gently press it on the posterior lip, this large nucleus is just going to come out in toto, in a single piece, and then we can put a IOL. So something which would have taken us a lot of time with phaco, with a lot of sweat and trepidation, is done very easily with SICS. And then of course we can clean this and we'll put in the lens. Similarly, a black cataract can also be done with the technique for visco expression. And in visco expression, instead of a sheath's glide, we pack the anterior chamber with visco, and again we press on the posterior lip. So here making the tunnel, making a good tunnel, is a very important step. Making a good incision is important even in phaco, but in SICS equally so, or even more so, because it's a larger incision, and it's an incision that has to be completely seal-proof, fool-proof, so that there is no leakage. The only difference between both of them is that in phaco, because the incision is smaller, the astigmatism is lesser. In SICS, because the incision is bigger, the astigmatism is more. And as you can see, the nucleus has just come out. So even for a hard brown cataract like this with a large nucleus, we need a large rhexis and a large tunnel with good scleral pockets. So this nucleus delivery can be the most traumatic step for the patient and the surgeon. Especially, I will not use the word conversion, because nowadays all our residents, the newer surgeons, learn on SICS. The tunnel has to be adequate and proper. We have to ensure that the nucleus is bathed in visco. And the delivery is gradual and controlled. Because if we get the nucleus out suddenly, then there is a chance that a PC rent can happen because of sudden decompression. And while doing all of this, we have to understand that corneal endothelium is irreplaceable. Tomorrow, if you have a rent, perhaps someone later can put in an iris claw lens or a scleral fixated lens. If we tear the iris, we can suture it. But if the endothelial cells are damaged, then we'll need to have an eye bank with us, because this may need a corneal transplant. So we make maneuvers away from the cornea. And as surgeons, we have to understand that there is a trade-off between lesser astigmatism, smaller incision size, and corneal clarity, endothelial cell loss. Many of us want to have a smaller and smaller incision, but in that we harm the endothelium, and that then can create problems for us. And of course, later if we think there is a post-op shallow AC, so we always say small incision cataract surgery. We don't call it a suture-less cataract surgery. We can always put a suture, because wound gape and iris prolapse can be problematic. They can cause endophthalmitis. They can cause astigmatism. By doing this, SICS gives the best functional vision, a good vision for distance, And thanks to the astigmatism, a good vision for near also. Something like multifocals. There are newer techniques, 2 millimeter SICS, intratunnel fracture, smart SICS, the Ranjan marker. But for all of this, I think we need a lot more research, we need a lot more data to actually say how safe and effective they are. So similarly for smart SICS, which gives a multifocal-like effect, something like the Sturm's conoid. And we have my senior from Pune, Dr. Santosh Bhide, who will be giving a lecture on SICS with premium IOLs. But something like this, if there is a large astigmatism, normally we would want, if we want to put a multifocal, it will be a multifocal and a toric. But here, by taking a larger incision on the steeper axis, we can actually even treat 2 diopters or 3 diopters of astigmatism. And we can give a very good vision both for distance and for near without using a toric IOL in SICS. So the more astigmatism can actually be used to correct the astigmatism that was pre-existing, in which case SICS becomes a technique of choice for doing cataract surgery. So it's not just small incision. It is, as Dr. Boramani said, a customized incision cataract surgery. So thank you once more. There are so many techniques, but we need more data. We need more this to show that other than the 2 established ones, viscoexpulsion and blue menthol, how good the rest are. Thank you.
Thank you, Dr. Gupte. That was a wonderful presentation, and like he said that there are various techniques and there may be as many techniques as many people in the hall. So whatever technique works best in your hands, which is safe for the patient, is important. Thank you so much. The next talk is by Dr. Santosh Bhide. He will be talking on SICS with premium IOL. He is the president of the Maharashtra Ophthalmic Society, which is one of the biggest society and which was host to the last year's conference. He has a large volume of SICS and phaco surgeries, and he will be now talking on SICS with premium IOLs.
Thank you, Professor Ragini Madam, for the kind introduction. At the outset, I would like to thank you and Professor Lahane sir for giving me opportunity to share my thoughts on this important topic of SICS with premium IOLs. I think my previous speakers have already talked about SICS, how it is beneficial, how to do it, how to manage astigmatism, and how to deal the hard cases. So basically, as we all know that cataract surgery has evolved into a refractive surgery. And with the introduction of newer instruments and phaco machines, it is going to be a boon for all of us, and it will become a refractive surgery. So as a SICS surgeon, can we incorporate premium IOLs in our practice? And if yes, what are the prerequisites and how to incorporate them? So first thing is that implanting a multifocal IOL is a science, but it also an art. And this art goes beyond evaluation of eyes of the patient, because you have to ask patient about the requirements depending on its occupation of the patient, and you have to assess the personality of the patient. So it also involves challenges in explaining intricacies of premium IOL technology to the patient. And the next challenge is to perform a perfect SICS surgery if you are planning a patient for premium IOL with SICS. So what are the different points which one must consider before taking patient for premium IOL with SICS? Usually I personally do phaco and then premium IOLs. But if I have to do SICS and think about premium IOLs, then these are the different points which one must consider. First thing is that whether there is a need of premium IOL, whether the need is for reduction of spectacle dependence or for freedom from spectacles. So you have to talk to the patient, you have to listen to the requirements of the patient and understand. There are certain patients who have type A behavior, who are very demanding. They want freedom from spectacles. In such patients, it is better to avoid premium IOL, whether you are doing phaco or SICS. because those patients will definitely cause a lot of problems to you in a post-operative period. But those patients who have realistic expectations out of surgery, and those patients who understand the limitation of technology, both the surgical technique as well as the premium IOL technology, definitely in those patients you can plan SICS with premium IOLs. The next question is which lens to choose. We know that there are so many lenses are available. If you go to the trade area, there will be, I think, at least 50 stalls. Everyone will be saying that our lens is the best technology, the newer technology. So whether to choose a multifocal lens or an extended depth of focus lens or a trifocal lens or a toric multifocal lens, that choice or that decision will depend on the surgeon, depending on the preoperative investigation of the patient and the requirement of the patient. Another points which one must consider before putting premium IOLs is assessment of preoperative astigmatism. I think surgically induced astigmatism is the most important point. Before going or venturing into premium IOLs in cases of SICS, you should assess your own surgically induced astigmatism. I feel that at least in hundreds of the cases, you should assess your own surgically induced astigmatism. And second important thing is that you should be able to deliver the same result to all the patients. The astigmatism, post-operative astigmatism has to be same in the patient. There are various factors which affect wound healing. We have listened to talk by Professor Ragini Madam on ocular surface disease. So if the patient is with ocular surface disorder, it is better to avoid premium IOL in such patients. We all know that surgically induced astigmatism depends on the size of the incision, the location of the incision, and the placement of the incision, whether you have placed that incision on an astigmatically neutral funnel. It also depends on different nucleus cracking techniques, which Dr. Gokte has already mentioned. So basically, we have to remove hard nucleus, a grade 4 nucleus, from a very small incision so as to give good results to the patient. Then and then only you should think of incorporating premium IOLs in your SICS practice. There are certain factors which you must understand for selection of the patient for premium IOLs. The first and the foremost factor is that patient should have strong desire for relatively spectacle independence. Second thing is that you have to ask the patient about his occupation and his functional activities. Especially those who are night drivers, it is better to avoid premium IOLs or multifocals in such patients. As I have already mentioned, those who are very demanding, hyper patients, critical patients, type A personality, it is better to avoid. If you find that there is irregular astigmatism preoperatively, in such patients, it is always better to avoid premium implants. If patient has previous history of refractive surgery like PRK or LASIK, it is better to avoid because IOL power calculation can be a tough job for such patients. And in such patients, it will be really, if you get a post-operative error, you will be in a problem. And those patients who have zonular dehiscence or weakness, better to avoid. Now, if you have planned a surgeon for premium implant, then a proper thorough preoperative evaluation is a must. You have to rule out corneal ectasia, zonular instability. You have to look for proper pupillary dilatation. You have to evaluate ocular surface. Detailed examination of retina and doing OCT is a must in such patients. For patients who have astigmatism, topography is mandatory before putting premium implants, and most important thing is accurate biometry. There are various surgical techniques, but I think 3 steps in our surgery are most important. First is capsulorhexis, second is tunnel construction, and third is nucleus management. As we know that capsulorhexis has to be properly centered. It has to be of adequate size of 5.5 millimeters to 6 millimeters. It should be properly centered on the visual axis if you are planning premium implant. A proper selection of viscoelastic device is a must. You have to use a high molecular viscoelastic like Helon for doing capsulorhexis. And one has to take care so that capsular axis does not extend to the periphery. While performing capsular axis, one should understand that there are 4 forces which are acting. The first force is extrinsic force, which is of a surgeon. Second force is a centrifugal force, which is by zonules. The third force is a leaking of viscoelastic devices out of the incision while performing capsular axis. This leads to shallowing of AC and thereby extension of rhexis to the periphery. And the fourth and most important factor is from behind, that is a vitreous thrust. So with the vitreous thrust, there can be shallowing of AC and that can lead to extension of capsular rhexis to the periphery. So a perfect centered of capsular rhexis of adequate size is mandatory if you are planning SICS. The next very important step is tunnel construction. Why this is not running? Sorry. In tunnel construction, the blade has to be perpendicular to the sclera before creating tunnel, and the depth has to be 50% of the thickness of the depth. As we know that you can take a frown-shaped or chevron or inverted bat-wing-shaped incision. When you are doing tunnel construction, when you go at the periphery, the corneal contours should be respected and it should be done in astigmatically neutral funnel. So if you take a location in a astigmatically neutral funnel, then definitely you will give a consistent and good results. The third most important step in SICS, if you are planning premium implant, is management of nucleus. The delivery of nucleus has to be through small incision so that there is no or minimally induced astigmatism. See, softer cataracts you can easily remove through any size incision, but if the nucleus is hard, then it is really difficult to remove that nucleus through a small incision. And in such cases, there are various techniques of intratunnel fracture. As we all know that there is a snare technique which was developed by Dr. Anil Shah, who is also from Maharashtra. He is from rural area of Nandurbar, and he uses steel wire to make a snare, and after performing CCC, he delivers nucleus into the anterior chamber, and then this nucleus is divided into multiple pieces by using this snare, and it is extremely cost effective and reproducible results can be achieved by this technique. There is an advanced technology which we all know that MyLoop technique is there. This is a manually operated device, and in this device a nitinol, that is a nickel and titanium filament of 300 microns is used instead of a steel wire, which has a good property of elasticity and a cutting force. And with this, we can cut hardest of the nucleus into multiple pieces. The most important feature of this is that it can be as small as 1.5 millimeters and it can expand into as large as 10.5 millimeters. And in this technique, the nucleus is divided into multiple pieces inside the bag as opposed to the technique of Dr. Anil Shah. There is another technique by Dr. Sudhir Singh in which an intratunnel phaco-fracture is done. There are other ways of managing astigmatism like customized incision cataract surgery in which you can take an incision on a steeper axis, thereby reducing astigmatism and giving better result. A smart SICS, which is a software-based incision technique. But for all of us, suture can also come to our rescue. If you take a proper suture, then definitely you can modify astigmatism and you can titrate astigmatism post-operatively also. So there are certain exclusion factors which one must consider, that if there is extension of capsular rhexis to the periphery or zonular damage, then you have to exclude. You should not put multifocal lens in such patients with SICS. To summarize, or to the take-home message in this talk is that proper understanding of the patient's needs and selection of premium implant according to the needs of the patient is most important. Pre-operative counseling, sufficient chair time should be given by the operating surgeon, and proper analysis of surgically induced astigmatism has to be done by a surgeon before venturing into premium implants in manual small incision cataract surgery. To choose implant, one has to be very wise depending on the current refractive error, depending on the needs of the patient and demands of the patient. And if the patient is not suitable for the premium implant due to his condition, it is better to tell that patient preoperatively itself. And the most important dictum is under-promise and over-perform. Thank you once again for the opportunity, and I hope this lecture is useful to all of you.
Thank you, Professor Bide, for making the thing simple and really emphasizing the points of utilizing the surgically induced astigmatism to correct the pre-existing astigmatism. So you can implant multifocal IOLs. And now we have Professor Lahane, who is a big name in ophthalmology, and Padma Shri. Professor Lahane is well known not only in Maharashtra but all over India, and we have been learning so much from him, and we know that he is a very, very hard working person. Even at senior surgeon level, he is doing such wonderful talks, high volume surgeries all around Maharashtra. So over to Professor Lahane, sir.
Thank you, Kamalji Singh sir. Now 6 unaided in SICS. So what happens whenever we are thinking of the SICS, we always think this is an inferior surgery. But what we do in JJ or in the camps also, definitely maximum patients they can get the good vision, that is a 6x6. Now who decided the benchmark? This benchmark was decided by the health mission, and this the National Health Services in 2004 decided that this is the benchmark, and benchmark is, you can say, the more than 90% post-operative within plus or minus 1 diopter. This is the benchmark till today, not changed. Now see, the refraction is, you can say, minus 1 diopter, or what went wrong. So why I can't see the last line? So this is always a question by the patient. And what I am missing, why I am missing this? It is because of the, you can see the checklist, measurement error, IOL calculations, or you can say in the calculation it may be a estimation of the post-operative IOL position, determination of the post-operative refraction, and measurement of the axial length may be wrong. Because of that, it is not possible to go to 6x6. And to avoid the measurement errors, you should go with the non-contact optical biometry, or you can also go to the immersion ultrasound. And this immersion, though you are doing the non-contact biometry, it is very important to go for the immersion biometry in mature cataract and the posterior subcapsular cataract. And then repeated measurements by yourself, not by the technician, will definitely help you. Now see what happens, the IOL calculation formula. There are so many formulas you can see. But see, in both extremes, the only validity works when you are going for the both extremes. And if the eyeball is short, normal or long, you can have the holiday 1 or the Hopper Q or SRKT, you can go, or Haggis. These are the formulas where you must use it whenever you are doing the calculations. Then the IOL calculations, you can see here, all this formula definitely helps us. Now another thing is the IOL position and the alignment of the IOL. The size of the capsular axis has a direct relation to the effective lens position. It's very important, because this effective lens position, always you can see it may be femto, we can cataract, zepto, or intraocular lenses, or intraoperative overlay. That always helps us. And here the capsulotomy, if it is a small size, that is less than 5.5, or the large size, what happens? You can get the anterior the capsular fibrosis or hyperopic shift if it is a small, and if it is a large, you will get the increase the rate of the tilt, or you can have the decentration. See here the lower line says that a difference of 1 millimeter in the lens position can cause approximately 1.25 diopter change in the refractive error. It means the effective position of the lens is very, very important whenever you are doing the premium lenses. Now intraocular lenses, now there are so many premium lenses, the trifocal, accommodative, multifocal, toric, and now we are shifting gradually towards the EDOF. The corneal pathologies, when there is a corneal pathology there, you must also, that will also affect the visual outcome. You see all these pathologies, whenever you are operating, you should do it. Otherwise, there may be a endothelial gatte you have operated, and second day patient is a white eye. So that you will have to see. You can also have the retinal pathology. So in the retinal pathology also you can see the cystoid or any other pathology, and that is always you can say post-operatively creates a problem. Now the site, it depends on the sites also. So whenever you are taking the incision, then you must know the curvature, and according to the curvature you must slightly change in this one. And second thing is pre-operative counseling. Now this is the main important thing, that we are just promising very high. Yes, you will get 6/5, you will get n by you can say n by 5, n by 3, n by 1, and the patient is happy. Yes, you just implant the IOL and you can read and you can do everything. So this is the only one problem by the over promises, and this over promises, I think, don't promise high sky, because see, we don't know what is going to happen. So whenever you are promising, promise realistic, and once you promise realistic, patient may go to the other doctor, but for the second eye patient will come to you, because high promises, the nothing, no, we can't, I think, provide such type of thing to the patient. And in summary, you can say the accurate IOL measurement is very important. You must measure it properly. Then the second is the correct IOL selection. Then updating the IOL constant. We must update our IOL constant. Then the retinal evaluation, topography, and the patient counseling, what I said. Now the perfection is not attainable, but if we chase the perfection, we can catch the excellence. It is possible, we can do it, but sometimes see what happens. You will have to chase it, what has happened in my eye, what is my astigmatism, why it is coming, where was my incision, and what I will have implanted, how much my rexis. If you see all the factors together, then definitely you can attain the good result, and you can go for the 6/6. So always plan for the 6/6, but not early. Gradually you can learn and you can go for the 6/6. Thank you very much. And now we have got some time of the 2.5 minutes, and if anybody want the questions, definitely we can ask answer the questions. Thank you very much.
Thank you so much, Professor Lahane. It was a wonderful session on 6, and one must consider monovision in giving the bifocality to the patient, which is so very essential. It's very cheap, and you can easily give 6/6 vision or 6/9 vision in the dominant eye, and in the other eye you can make them myopic, and you will not need glasses most of the time. So this is what you can add with the SICS, and one can do wonderful job with the SICS. Thank you so much, sir. Dr. Agni?
Thank you, sir. I agree with you. And thank you, friends, for being here for this session. And if anybody has to share something of their own or give tips to anybody, I think those are also welcome. Lane sir, final words. Parikshit bhai, Santosh bhai, and then Lane sir, final words.
I think the SICS is here to stay, and whenever I think you are operating with SICS, don't feel that you are inferior surgeon. It is one of the surgery accepted, that SICS, and yes, you can learn phaco, and those who are doing SICS, for them, FECO is always better. So thank you very much. Thank you for sitting for 2 hours. Thank you very much.
So we'll take a group photo.
So
One
even
of
if
the
you are a prolific
organizers-
FECO surgeon, you should be able to do SICS also properly.
I think
Because
one of the
FECO, SICS will bail out from any complications. So even if you are a good FECO surgeon, you should be able to do SICS.